All right, welcome to Chapter 3, Medical, Legal, and Ethical Issues. I'm going to be honest, most students either love this chapter because it makes them feel confident and professional, or they hate it because it's not fun skills. But this chapter is a huge part of what makes you a safe EMT. Because here's the truth. You can't be great at bandaging, splinting, and assessments and still get yourself into some serious trouble if you don't understand consents, refusals, confidentiality, and your legal responsibilities. The National Registry loves this chapter because it tests how you think. These questions often aren't about medicine, but more about what's appropriate, what's legal, and what protects the patient and you. This chapter is part of the preparatory standards. This means these are foundational responsibilities that apply to every call. It basically says you must apply foundational knowledge of medical, legal, and ethical issues to emergency care. So as you're learning this chapter, don't think of it as a list of rules. Think of it as, how do I make decisions in a way that I could defend in court, defend to my medical director, and still be proud of as a professional? This slide lists specific topics that you're expected to know: consent, refusal of care, confidentiality, advanced directives, evidence preservation, and statutory responsibilities. I want you to notice something though. None of these are cool EMT skills, but these are things that make you a safe provider who doesn't create legal problems. And the National Registry questions oftentimes live right here, especially in refusals, consent, and confidentiality. These are the ones that students tend to get tripped up on because they want the medical answer, but the test wants the legal, ethical, and safe answer. This slide continues that list: mandatory reporting, ethical principles, and moral obligations, as well as end-of-life issues. This is where you learn how to handle tough situations, suspected abuse, DNRs, family conflicts, and when care decisions are complicated emotionally. As an EMT, you're not making long-term care decisions, but you are responsible for knowing what you can do, what you must do, and when you need to bring in medical control. Let's start with the big picture. This slide sets up a key point. EMTs generally avoid legal problems when they act in good faith and according to the appropriate standard of care. Good faith means you're sincerely trying to help and you're not being reckless or malicious. Standard of care means you act the way another EMT with similar training would act in the same situation. So when you see the phrase standard of care, think reasonable EMT care based on training and protocols. This chapter is going to teach you how to consistently provide care that is reasonable, defendable, and professional. Now we get into consent, one of the biggest topics in this chapter. Consent is the patient giving you permission to treat and/or transport them. But here's the key: consent requires decision-making capacity. A patient must be able to understand what's going on, understand the risk and benefits, and make a choice. Adults with capacity have autonomy, meaning they get to make the decisions about their body, even if you disagree, even if it's a bad decision, and even if it scares you. Your job is to make sure the patient is informed and that you documented what happened. This slide continues the consent discussion and ties to what the patient must understand. When you're getting consent, you should be thinking, do they understand the situation? Can they repeat back the risks? And are they making a voluntary decision? This matters a lot because refusals and consent issues come down to one question: did the patient have capacity? And capacity can be affected by alcohol or drugs, head injuries, low blood sugar, hypoxia, shock, mental health crises, or even fear and distress. So if you have to assess more than their words, you assess whether the decision makes sense based on their mental status and the situation. Express consent is straightforward. It's when the patient clearly indicates they want care. This could be a verbal, yes, please help me, or it can be nonverbal. They hold out their arm for you to take their blood pressure with a cuff, and then they nod and cooperate with the care. But here's the part some people forget. Express consent should also be informed. This means that you explained what you're doing in a way that they can understand. In EMS, we're not doing a long hospital style consent for every action, but we are expected to communicate clearly. So even simple lines matter, like, is it okay if I check your blood pressure on this arm? Or is it okay if we put you on some oxygen to help you breathe? Implied consent is an emergency doctrine. This applies when a patient is unconscious or otherwise incapable of making an informed decision and there's a serious threat to life or limb. The law assumes that a reasonable person would want care. So if you find someone unresponsive and not breathing normally, you don't stand there waiting for permission. Obviously, we act and begin CPR. Now, if the family is present, you can try and involve them, but we do not delay any life-saving care to chase consent. This slide also adds a very important warning. Implied consent should never be used unless there's a threat to life or limb. So implied consent is not for convenience, it's not for when our patients are being difficult, and it's not for if they seem confused but we want to transport them. It is strictly when the patient cannot consent and urgent care is needed. It also mentions trying to get consent from a spouse or relative. That's great when they're available, but again, we're not going to let that delay any immediate life-saving interventions. Involuntary consent. This is about patients who cannot consent due to specific legal or mental health reasons, such as a mental health illness, a behavioral crisis, or a developmental delay. Oftentimes, this involves a guardian or a legal authority. The key phrase here is not always possible to obtain that person quickly, which is why we need to understand our local laws and protocols. This is also where law enforcement may play a role depending on our system. As an EMT, our safest approach in these situations is to focus on safety, use de-escalation techniques first, involve our medical control early, and to document everything. Now we're getting into minors and consent. The general rule is a parent or legal guardian gives consent to treat a minor. This slide also notes that in some states, a minor can consent depending on the situation, and it mentions teachers or school officials that may act in place of parents. So in the real world, if you're at a school and the parent isn't there, we follow our local policy. Oftentimes, a school officiant can help with obtaining parent permission while we provide appropriate care. And if it's a true emergency and there's no guardian available, remember, implied consent may apply here because we are not going to delay any life-saving care. This slide discusses forcible restraint, which may be necessary when a patient is a danger to themselves or others. Restraint is generally a last resort and should only be used when de-escalation has failed or the patient poses an immediate threat. Whenever possible, restraint should be applied only with medical control involvement and law enforcement assistance. Patient safety and provider safety are both priorities. Once the restraints are applied, do not remove them unless they endanger the patient. Be sure we continuously monitor the airway breathing and circulation of the patient and document the reason for the restraint and the patient's behavior. Improper restraints can cause serious injury or death, which is why it must be used carefully and appropriately. Now we move on to refusal of care, which is one of the most legally risky situations we can find ourselves in EMS. A competent adult has the right to refuse treatment or transport, even if that refusal could result in serious harm or death. Our responsibility is not to force care, but to make sure the refusal is informed, voluntary, and documented. This slide explains the requirements for a valid refusal. The patient must be an adult, have decision-making capacity, and understand the risk of refusing care. Our role here is to clearly explain what we believe is happening medically, what care we would recommend, and what could happen if they refuse. The conversation should be calm, professional, and respectful. This slide focuses on best practices during a refusal. We should try and involve medical control whenever possible, encourage the patient to accept care again, use a witness if available, and obtain a signed refusal. If the patient refuses to sign, document that clearly and include a witness name. Our responsibility doesn't end the moment the patient says no. Before we should leave the scene, we should always encourage the patient to seek care if symptoms worsen. Explain that the person can call 911 again at any time, and leave the patient in a safe environment. A proper refusal should never be rushed or dismissive. Now we transition into confidentiality, which is a fundamental patient right. Any information we learn about a patient, including their condition, treatment, or the fact that we even treated them, is confidential. As an EMT, you are legally and ethically required to protect that information. This slide explains protected health information, also called PHI. PHI includes patient names, medical history, assessment findings, treatments provided. This information can only be shared with people who are directly involved in the patient's care. This slide also introduces HIPAA, the Health Insurance Portability and Accountability Act. HIPAA establishes national standards for protecting patient information. Violations can result in fine, criminal charges, and loss of certification. HIPAA applies both on duty and off duty. This slide also addresses confidentiality in the age of social media. Posting about calls, scenes, or patients, even without names, can violate HIPAA if the incident is identifiable. The safest rule is simple. If the public could identify the patient or call, don't post about it. Better yet, just don't post about it. Now we move into advanced directives, which are legal documents that express a patient's wishes about medical care if they become unable to make decisions for themselves. Advanced directives exist to protect patient autonomy. They tell us what the patient wants, not what the family wants, not what we want, but what the patient has decided ahead of time. As EMTs, you are expected to recognize advanced directives and follow local protocol when one is presented. This slide introduces common types of advanced directives you may encounter. These can include living wills, durable power of attorneys for healthcare, or physician orders related to life-sustaining treatment. The exact names and formats may vary by state, which is why protocols and medical control are so important. Let's talk specifically about DNRs, or do not resuscitate orders. A DNR means do not begin resuscitative efforts if the patient is in cardiac or respiratory arrest. It's a very important clarification. A DNR does not mean do not treat. Patients with DNRs are still entitled to oxygen, pain management, comfort care, and treatment of reversible conditions. This slide introduces the POLST or MOLST forms. These are medical orders that go beyond a traditional DNR. They may specify whether to provide resuscitation, whether to provide advanced airway management, and whether to transport to a hospital. These forms are designed to provide clear, actionable instructions for EMS. This slide addresses a common real-world situation. What if you think a patient has an advanced directive, but you can't find it? If a patient is in cardiac arrest and no valid directive is immediately available, begin resuscitation. You can always stop later if a valid directive is produced or medical control advises otherwise, but you cannot undo a failure to act. Now we transition into death and dying, which is an area that requires both clinical judgment and professionalism. As EMTs, you may be called to scenes where death has already occurred. Your role in this situation is to recognize signs of death, follow protocol, preserve dignity, and notify appropriate authorities. Presumptive signs of death. These include unresponsiveness, absence of breathing, and an absence of a pulse. Presumptive signs suggest death but do not confirm it. Resuscitation is usually initiated unless there are definitive signs present or a valid DNR exists. Listed are some additional presumptive signs of death: absence of eye movement, no blood pressure, profound cyanosis, or decreased body temperature. Definitive signs of death. These are signs in which confirm that death has occurred. Some examples include decapitation, rigor mortis, dependent lividity, shown here in the picture, putrefaction. When definitive signs are present, resuscitation is not indicated. This slide reinforces that when death occurs and is obvious and irreversible, EMTs should not initiate resuscitation, but preserve the scene and notify appropriate authorities. Always follow your local protocol and medical guidance. ME cases. This slide discusses cases that require notification of the medical examiner or coroner. These situations commonly include suspicious deaths, violent deaths, suicides, accidents, death without a physician present, infant deaths, and such. Your responsibility is scene preservation, not investigation. Some special situations. Organ donation. A patient's status as an organ donor does not change our responsibility to provide life-saving care. Organ donation decisions are handled later by the appropriate agencies. Medical identification jewelry, such as bracelets or necklaces. These can provide critical information about a patient, including medical conditions, allergies, advanced directives. These should always be noted and documented. This slide introduces scope of practice, which defines what an EMT is legally allowed to do. Your scope of practice is determined by state law, national EMS education standards, and your medical director and local protocols. Scope of practice is not determined by your employer, your partner, or your confidence level. Just because you've seen something done or feel capable does not mean it is within your scope. Operating outside of your scope, even with good intentions, can result in legal action, loss of certification, and criminal charges. This slide builds on scope of practice by introducing standards of care. The standard of care refers to how a reasonably prudent EMT with similar training to you would act in the same situation. Standards of care come from laws and regulation, EMS protocols, textbooks and training, and accepted professional practice. On the National Registry, questions will often ask whether an EMT acted according to the standard of care, not whether the outcome was good or bad. Duty to act refers to your legal obligation to provide care. You generally have a duty to act when we're dispatched and on duty. You begin patient care. Or, once you establish patient contact and begin care, you simply cannot leave unless care is transferred appropriately, the patient refuses care, or you are relieved by a provider of equal or higher level training. Off-duty EMTs may have a moral obligation to help, but usually do not have a legal duty unless specified by law or employer policy. This slide discusses negligence, which is one of the most tested legal concepts on the National Registry. Negligence is failure to act according to the standard of care, resulting in harm to the patient. To prove negligence, there's 4 elements that must be present. You had a duty to act, you had a breach of duty, there were damages that were a result of your duty or breach of duty, and a causation. If one of these elements is missing, negligence has not occurred. Abandonment occurs when an EMT terminates care without the patient's consent or without transferring care appropriately. Examples of abandonment may include leaving a patient after initiating care without transfer, leaving a patient who cannot care for themselves, or failure to give a proper handoff. To avoid abandonment, you should obtain a patient refusal when appropriate, transfer care to another qualified provider of equal or higher level training, and clearly document the transfer of care. Assault and battery. These are both criminal acts. Assault is the threat of unlawful touching, and battery is the unlawful touching itself. Performing a medical procedure without consent can be considered battery, even if the procedure was medically appropriate. False imprisonment and kidnapping. False imprisonment occurs when a patient is restrained or confined without legal justification. Kidnapping refers to transport of a patient against their will without any legal authority. This is why consent, capacity, and assessment, and proper restraint procedures are so important. Defamation. This involves damaging a person's reputation by making false statements. Libel is a form of written defamation, whereas slander is a spoken defamation. As EMTs, we must be careful how we speak about patients and coworkers, especially in documentation and public conversations. Good Samaritan laws. These are laws that protect individuals who provide emergency care in good faith. These laws generally apply when you act voluntarily, you are not paid, you act within your training, and you do not act with gross negligence. Good Samaritan laws encourage people to help without fear of legal consequences. One thing to note, Good Samaritan laws do not protect against gross negligence or actions outside of your training. This slide introduces documentation, which is one of the most important responsibilities you will have as an EMT. Your patient care report, or PCR, is a legal document. It is often the only permanent record of what happened on scene, what you did, why you did it, and what you found. This documentation serves several purposes. It communicates patient care to other providers, it provides a legal record of your actions, and it supports quality improvement in billing. It protects you and your agency in court. A common saying in EMS is, if it wasn't documented, it didn't happen. And legally, that's often true also. This slide introduces mandatory reporting, which refers to situations where EMTs are legally required to notify authorities. Mandatory reporting varies by state, which you'll receive more training on specific Virginia mandatory reporting, but commonly includes suspected child abuse or neglect, elder abuse, sexual assault, certain communicable diseases, domestic violence, and other special circumstances. As an EMT, our role is not to investigate, it's to recognize and report according to local law and protocol. Ethics in EMS. Ethics help guide decisions when the law does not give a clear answer. As an EMT, you are expected to act honestly, treat your patients fairly, respect patient dignity, maintain confidentiality, and provide care without discrimination. Ethical practice builds trust between EMS and the community. Bioethics. This applies ethical principles to medical care. Common bioethical principles include autonomy, which is respecting the patient's right to choose; beneficence, acting in the patient's best interests; non-malfeasance, doing no harm; justice, which is treating patients fairly. These principles help guide difficult decisions, especially when there's a conflict or uncertainty. EMS often presents us some significant ethical challenges. Some of these examples include conflicts between family members and patient wishes, end-of-life decisions, limited resources, treating difficult or uncooperative patients. In these situations, we rely on our ethical principles, our protocols, our medical control, and our professional judgment. The EMT in court. This slide teaches you how to behave if you have to testify in court. Some key points include dressing professionally, speaking clearly, answering only the questions that are asked, do not guess, and if you don't remember, just say so. We'll discuss this a lot more when we get into specific documentation regarding PCRs, but your PCR will be used to refresh your memory, which is another reason that accurate documentation really matters. Your PCR may be reviewed months or even years after the incident. Clear, factual documentation is going to be your best friend in this situation. It should support your testimony, demonstrate professionalism, and show adherence to the standard of care. Poor documentation can undermine otherwise good patient care. Chapter 3 focuses on medical, legal, and ethical responsibilities of the EMT. And this chapter is critical because it guides how and when you are allowed to provide care. In this chapter, we learned that EMTs must always act within their scope of practice, follow local protocols, and provide care according to the standard of care. Good intentions alone do not protect you legally. Your actions must be reasonable, appropriate, and consistent with your training. We discussed consent, including express, implied, and involuntary consent, as well as consent involving minors. We also covered forcible restraint, emphasizing that this is a last resort only used when a patient poses an immediate danger and that restrained patients must be continually monitored. We spent a significant amount of time on refusal of care, which is one of the most legally sensitive situations in EMS. Competent adults have the right to refuse care, and EMTs must ensure that refusals are informed, voluntary, and thoroughly documented. This chapter also addresses confidentiality and HIPAA, reinforcing that the patient information must be protected at all times, to include social media. We reviewed advanced directives, DNR orders, and end-of-life considerations, including recognition of death and ME cases. These topics require EMTs to balance clinical judgment with respect for the patient's wishes and legal requirements. Finally, we covered documentation, mandatory reporting, ethics, and the EMT role in court, emphasizing that accurate, objective documentation is one of your strongest legal protections. Overall, Chapter 3 teaches EMTs how to think professionally, act ethically, protect patient rights, and protect themselves legally, skills that are just as important as any medical interventions you will perform.